Good morning, I'm Jessica Lovell, and welcome to the Morning Medical Update. Today, we continue our series devoted to prostate cancer. Very common and very curable when it is caught early. We have already had the pleasure of speaking with several great patients who advocate for themselves and for others. And today, we are focused on the importance of knowing your family history and what to do if that history includes prostate cancer. We are joined again today by Dr. Will Parker, urologic oncologist here at the University of Kansas Cancer Center. Are you getting tired of us yet?
Not yet.
Never tired of talking about prostate cancer and educating everyone, and then introducing us to some great guests, by the way. You're a surgeon who deals exclusively with prostate cancer, and you've really been the catalyst for this entire series, so we appreciate that. And you have introduced us to these, I keep calling them the brothers. That's why I've just been calling them the brothers. These two brothers, they lost their father to cancer, but they took it upon themselves to be proactive about their own health. Here's Janine Kiesling.
Brothers Mike and Matt Boatwright have a lot in common, a love for their families.
This is the room for my grandson, and this is where he wants to be.
Fishing.
I launched it across the river into the tree.
Did you lose the lure?
The lure was gone.
And spending time on the water when they can get their boat to cooperate.
But I think we'll be ready if we go out the next time, hopefully.
The one thing they didn't want to share was their experience with prostate cancer, a challenge they first witnessed in their father.
Just watching Dad go through this, it's like, oh no, how bad is this? I mean, you just had no clue. You'd seen him have a different treatment, and it didn't work.
Motivated by their father's fight, Mike and Matt became proactive about their own health.
I mean, if Dad had it, he's got it, I got it. It just makes sense that once Dad got it, that we should be vigilant about that. I think everybody should.
Mike got the news first, and shortly after, Matt received the same diagnosis.
It just was his concern, who do I go to, who do I find?
Mike turned to a trusted medical professional.
I said, who would you recommend? And said, well, if it was my dad, I would. And so that's how I came to Dr. Parker.
Soon, Mike was headed to the University of Kansas Health System for laparoscopic surgery. He was relieved when the surgery was successful, but he still needed a few rounds of radiation to reduce the chances of the cancer returning.
They were confident, and they should have been. They did what they said they'd do. The one thing about the radiation, it really was easy.
Seeing his brother's success encouraged Matt to take a similar route. He made the shorter trip from Topeka to KCK for his surgery in May.
It's amazing how quickly you can recover.
Now both brothers are doing well and excited about what the future holds, especially more fishing together. They hope their story inspires other men to take charge of their health.
You just need to wake up, keep it checked.
Wake up and get checked. That's a great message from Matt and Mike Boatwright, who are joining us live this morning. How are you guys doing today?
Good. Very good, Jessica. Thank you.
You guys seem like a lot of fun. I want to come hang out in that garage. You guys seem like you're a lot of fun, a lot of trouble. But most importantly, your story really underscores the importance of knowing your family history. You shared some really great photos of your dad and yourselves through the years. Tell us about his cancer journey. What do you remember about that time when he was diagnosed, when you were young?
Well, I remember that he, had prostate cancer, and it was like, okay, what is that? And he decided he had the option to either have cut out or they were doing seeding. I don't know if they still do that or not. And it seemed to work.
Matt, what do you remember?
It did.
Well, I remember I think I was in my early 40s around that time, and I had little children. And when they seeded Dad, they used radioactive seeds, I guess, they placed into his prostate. And at that point, what I remember is the kids couldn't sit on his lap anymore because of the radiation of the pellets they used.
I want to bring in Dr. Parker. What's seeding, since they brought it up?
Yeah, so seeding is called brachytherapy, which is internal radiation, and we do still do it. So towards your question, it is something that we do as part of one of the ways that we can treat with radiation. Essentially, they're little titanium pellets that are embedded with a radioactive element. Typically, it's radioactive iodine, cesium, or palladium, towards, again, what it was. And you remain radioactive for about 6 months.
Right, because we talked about that, or you have to maybe keep your distance. And
Correct.
I always say, if your grandkids can't sit on your lap, you know it's really, this is interfering with your life, but it's such a good thing that he got checked out. But did you guys know if anybody else in your family had cancer, prostate, or any other type of cancer?
Seemed like Mom had some melanoma.
Mom had breast cancer and melanoma. But beyond that, our grandfathers died really pretty early in their 60s. And I'm not aware of any other prostate cancer in the family other than Dad.
With Dad, did he talk about symptoms? Do you remember him having symptoms or him changing at all that you noticed from just a son watching their dad?
I don't remember. It just appeared. I'm not quite sure how it was identified.
How long was he dealing with prostate cancer before he ended up passing away?
Oh, God, almost 30 years.
How was that for your family?
It didn't seem to slow him down much. He got the treatment he needed, and I think it would have been nice if we could have addressed it and got it taken care of and not had it metastasized, but he was able to get treatment and lived for a long time.
But it did change you because you used this diagnosis really to start managing your own health, right? Tell us about that.
Well, when I was about 50, I had a GP, very good GP, I miss him. Said, well, we're going to start testing for prostate. Okay. And it was fine. He said, if it ever develops, we just need a baseline. Sounded reasonable to me. It was just a blood sample. And so we continued to check that throughout the years.
So you got your PSA checked?
Yes.
Dr.
So
Parker.
we got, so finally the PSA started to climb. This was 2019? And I think that's correct, yes. And had, it definitely climbed. And I had a doctor at the time that was a smaller Oriental woman who had tiny hands, and we did the finger test and didn't feel anything, but he said, no, I'd like for you to go see a urologist. Well, the urologist had hands the size of good-sized pork chops, and boy, he checked it, and you could just feel his finger roll over a marble. That was it. So
Mike, thank you for your very specific description.
That was a little gross.
We could almost feel it ourselves. Thank you very much. So let's bring in Dr. Parker. Let's talk PSA. We have to talk about that because if somebody hasn't heard of it, what is it? What's it supposed to be? When is a climbing number something that means you should come see your doctor?
Yeah, so PSA is a blood test, prostate-specific antigen, very easy screening tool that we use to screen for prostate cancer. The range of PSAs really depends on how old you are. So for instance, we recommend now getting PSAs tested in the 40s, 45 for your average risk person, 40 for your higher risk individual. The average PSA at 40 is about 1, so anything over 1 would be concerning. One of the challenges of that is most labs put this kind of arbitrary threshold at 4, where if you're under 4, you're fine. If you're over 4, you're not. And the reality is if you're 40 and your PSA's 3, that's a real big red flag and a real big problem. But that's what PSA is, and it's the first step in the process.
So Mike, you eventually learned that you have prostate cancer.
Yes.
And then Matt, you came next, right? Tell us how you both got diagnosed, what was that like?
Well, I got diagnosed during my regular physical. And again, yes, PSA tests were done annually pretty much since Dad contracted the disease. And mine ultimately popped over 4 as well. And that drew the attention and got me a referral to a urologist.
Mike, what was it like when you were diagnosed?
I kind of graphically just described it. No, it was a PSA. It definitely, it was over 4, and that was the red flag, and that's what started the process of.
Were there any symptoms, just your day-to-day? Were you feeling any different?
I had a swollen prostate, so you could feel that it was swollen, and some interruption in urine flow.
All right, Dr. Parker, how do you treat this?
Well, it depends on how aggressive it is. So prostate cancer, like most diseases, exists on a spectrum, and there are cancers that are less aggressive and don't require treatment. They can be monitored closely. And then other ones that do require some form of therapy, either surgery, radiation, or a combination of the two.
All right, he mentioned a symptom, and I have to ask you, when you say you have a swollen prostate, how do you know it's swollen?
Well, typically what that's referring to is urinary symptoms or obstruction. So intermittent flow, start and stop, wake you up at night. Those are the classic symptoms that we kind of attribute to the quote unquote swollen prostate or prostate enlargement, depending on how you phrase it.
And that's, yeah, the urinary issues are something we've heard a lot from the patients that you've introduced us to. We know early detection screening can save lives. Is there a genetic test that brothers, siblings, kids of someone who's had prostate cancer should be getting?
Not, at least currently with the way insurance works, there's no genetic testing that would be approved by insurance if you are not personally diagnosed with prostate cancer. But if you have a family history, you need to be screened, because we know that the risk of prostate cancer goes up when you have those relatives that have a history of prostate cancer or related cancers like pancreatic, ovarian, breast.
When can you get that screening? How old?
So we recommend 45 if you don't have a family history, 40 if you do.
So is it really upon you to know that history? Is that something doctors ask and you fill out the forms? But how early should people be really having these conversations? I mean, if you don't know, you don't know.
Yeah, that's the hard part is again, if you don't know to advocate for it. You don't know to ask. And not every primary care physician is going to necessarily offer PSA testing if you don't ask for it. Towards the point about family history, not everybody's parent actually talks about what they've been through. And I think generationally, you see certainly there's a kind of a group of men who just don't talk about their health and would have never volunteered to their children, I had X, Y, or Z problem. So they don't know. So
my grandfather died of prostate cancer. What does that mean for my dad?
Yeah, so his risk is twofold higher than what the normal population risk is. So the normal risk is 1 in 8 men. And so it's twice as high for him as it would be for somebody else just walking around on the street.
So what about my son? So how does the generational skip work?
So it starts to kind of water down. So as genetics work, as you start adding more people in, the risk starts to drop. So it's about 1.5-fold higher if you have a second-degree relative, so a grandfather, an uncle, not that first-degree relative, father, brother, child.
So how often do you meet with people who just don't know? You say, do you have a history of prostate cancer? And they go, I don't know. And then where do you send them to find that information?
More than half of the time, it's the I don't know. I send them back to their family. I just stress to them, go home, have a conversation with your family members, ask them. Ask the aunt who likes to talk about, your dad or whoever, and just find out the information that maybe you don't have.
So they get a screening. Is there anything else they should be doing as somebody who may be at a higher risk?
Yeah, trying to be as healthy as you can. I mean, prostate cancer isn't something that you can necessarily affect the risk of. So there's nothing that I could say, do this and your risk is going to go down. That's not going to happen. But if you are diagnosed and your health isn't as good as it could be, the options that you have for treatment may be limited. And so I think the most proactive thing men can do is just try to remain healthy. And I mentioned on a previous show, at the end of the day, men are more likely to die of heart disease than prostate cancer. And so if I were to make any recommendation about what could you do if you're at risk, try to do heart-healthy things.
Yeah, take care of your heart. We've talked about BRCA, BRCA gene here on the program, how it impacts women. That's maybe what we naturally think about when we think about breast cancer, but it also plays a role in prostate cancer.
It does.
That was news to me. Explain.
Yeah, so it plays almost the exact same role as it does in breast cancer. So kind of if you talk to most researchers, they would tell you that if somebody had studied it in prostate cancer first, it probably would have a different name, because the BR refers to the breast cancer related gene. It probably would have been PRCA if they had studied in prostate cancer first. That's how much it increases the risk. Essentially, men who have a BRCA2 mutation, which is the one that is the higher risk mutation for both men and women, the risk of prostate cancer is almost 8-fold higher.
So should people, I mean, I guess if you think you have this family history, there might be this feeling of, I feel doomed, you know, I have something, you know, something's coming, you know. How do you replace that feeling of possible doom with empowerment?
Yeah, I think it goes back to what I said about there's nothing you can do to impact the prostate cancer risk, so focus on the other things you can. Heart health, general health, living life to its fullest, taking advantage of things like fishing trips and scuba trips and all the things that people love doing in life.
Feed your soul.
Correct.
There you go.
And don't focus on whatever the genetic risk is.
Don't focus on what you don't have yet.
Correct. Let us focus on that. I'll take that burden and worry for you. You worry about the other stuff. Have fun.
Worry about fishing, guys. Okay, so be sure to ask your questions. You could use the chat on YouTube or Facebook. You could email the Medical News Network. The information is there on your screen. So, Matt and Mike, before you were diagnosed, did you feel that concern, that anxiety about this possibly could happen to us? Or were you just kind of waiting it out?
It wasn't a concern for me. I have a tendency to do that. I've told Matt I go into things a little dumb. No, as long as I'm getting my PSA checked, I know what's going on. It's just not a big deal.
Yeah,
well, you were doing
I'm
all
the
you
same
could do,
way. I didn't really feel any real concerns. I just knew that I needed to be my own advocate and to stay up on my physicals and my tests.
So you both had surgery regarding your treatment. You both had surgery. Mike, you had some radiation after. We've learned this month that patients need a catheter for some time after surgery. So Mike, how was your recovery after the surgery? How did you manage all that?
Kegel.
That's a whole other show. That's a new word, huh? Okay.
It really was. It was. It was a Startler buying diaper. Never done that before, and that didn't last very long. The catheter came out. It really was fairly easy. I don't remember it being. It was a nuisance, but it didn't last very long. So the recovery was pretty well.
What about radiation? Any side effects to that?
Yeah, I've been dealing with, yes. That was an interesting machine. Yes, it's starting to close. It's affected the flow. And there was a little bit of valve looseness, not being able to control it, and that went away. So it's been okay, but there were some side effects.
So Matt, did watching Mike go through surgery help you prep at all? Did you have questions?
Oh yeah. We sat down at least twice before my surgery because I had some very specific questions, and I went into it. I kind of went into it dumb a little bit, and that's maybe helpful. The catheter for me was what worried me the most. And it really ended up not being that big of a deal. You wake up with it in you, so you don't really even.
You got used to it.
Yeah, you got used to it. And then in a week, it was gone. And yeah, it wasn't really that bad.
So Dr. Parker, different kinds of prostate surgery, did they get the same one? And what are options when it comes to surgery?
Yeah, so I mean, Generically, yes, they had the same surgery in that they had a robotic prostatectomy. Now, what we did during the procedure was different between each of them, and it was tailored to the disease that we were treating. So, what I did for Mike wasn't necessarily exactly the same thing as what I did for Matt. Just, again, based on where the cancer was, the aggressiveness of the cancer, trying to meet the cancer where the cancer was, to tailor that treatment to them.
How far have we come since back in the day when the brother's dad was diagnosed and going through treatment to where they are today?
I think the best analogy I could give you is imagine the first cell phone you ever got and imagine the cell phone you have now.
Really?
That's the magnitude of the change that we've had as far as prostate cancer treatment.
Mike, Matt, what was it when you first heard of Dr. Parker? Tell us about that experience, because you were referred here, but I just wanted to see what it was like when you first met him.
I felt Dr. Parker's a pretty confident guy, and he exuded that, and it rubbed off on me, and I felt comfortable and acknowledged. It really was. It was a great experience. I appreciate it, Doctor.
My pleasure.
So, what do you make of these two guys? Is it often that you handle, keep it in the family and treat family-wide prostate cancer?
I think this might be a first for me.
Well, we're just so glad to meet them. They've been a pleasure to work with. So I want to go back into this garage because this looked very cool, like just a cool Zen place to hang out. What's your day-to-day life like now? Matt, I'll start with you.
Well, I probably did everything backwards in my life. I moved out to a 10-acre property right after I retired, and it's a lot of work. So whenever I do get a free moment, I like to go fishing. It's one of the most relaxing things to me.
Mike, what about you?
Yeah, I've got something that keeps me very busy as well.
Good. Mike, what about you? How are you feeling?
Well, right now I'm going through some other health stuff, so I'm not as mobile as I used to be, and trying to doing more genealogy and messing around on our place. If it has a motor, I'm working on it.
Well, I was going to say, you guys have taken your namesake quite literally. The boat rights and the boats. You guys really, really get out there, and I think people appreciate that, seeing people going through health issues, but then, only letting that take up a certain amount of space in your life, leaving plenty of time for what really matters. And I want to take a look at some photos, and I know that you've had, who are these lovely people?
Well, that is my wife, Patty, and my two children, Austin and Miranda. That is off Waikiki Beach in Hawaii, and that's where we got certified to scuba dive.
Fantastic. I think you have another photo. Who's this, Brenda?
Yes, that's my wife. We went down to Arkansas to watch the eclipse, which was pretty cool. So we're wearing our "Hello Darkness, My Old Friend" t-shirts.
I'm not surprised. I love it, guys. I love it. I love you guys living life. I want to get to some questions, though, from our viewers this morning. Stu wants to know, besides BRCA, are there other genes that we know increase prostate cancer risk?
There are. They all have funny gene names, things that you wouldn't necessarily hear about, like PALB2, HOXB13. Really, it's the genes that increase the risk of colorectal cancer. So there's a very common, or not common, but a well-known condition called Lynch syndrome, which increases the risk of colon cancer, greatly increases the risk of prostate cancer. And so it really comes to understanding, do I have that family history of related cancers? And then we go and search to see if we can find a mutation that fits the story.
Okay, so on that same note of genetics, Yen wants to know if my mother or female relative with who I share blood relationship have been diagnosed with breast or ovarian cancer, should I, as a male, also be concerned of my risk of prostate cancer?
Yes,
okay.
Absolutely. And so that's one thing I think we focus a lot as guys on, well, if we're talking prostate cancer, I need to be thinking about prostate cancer family history. The other family histories matter too.
I want to ask Gene's question just in case he missed it earlier, but the genetic tests, there are genetic tests once you have prostate cancer. Can you discuss those?
Yeah, so the way genetic testing works, we have genetic counselors, so KU being a comprehensive cancer center, we have genetic counselors that focus on folks who have a genetic predisposition. They take a family history and then run a panel of tests to see what would be appropriate for that patient.
Jill wants to know, why do doctors want to wait and watch some prostate cancers and not others?
So the lowest grade prostate cancer we can find, grade 1, there's a 99.9% chance that men don't die from that prostate cancer, no matter what they do. Head in the sand, walk out, nothing, 99.9% chance. And because of that, treatment for those men would represent risk without benefit. So we watch. And then if they do develop something that requires treatment, then we intervene.
Okay, Jeremy wants to know, should you get both the PSA test and the rectal exam annually, or is it just the one annually and then you do both if you think you find something suspicious?
So definitely PSA annually. The digital rectal exam, there's a lot of mixed opinions and feelings on that, both from patient perspective and physician perspective. I personally recommend you should at least have a baseline digital rectal exam. If there is some nodule or something there, we can feel it. If the exam is normal and you're skittish about having that exam done, then I don't think you're necessarily hurting yourself by maybe doing it less often than annually.
Okay.
But periodically, I mean, the prostate is thankfully in a position where we actually can feel it. Not a lot of other parts of our body can you put a finger on something and say, is there a problem?
Gotcha. Okay, I have a question. I don't know if it's a really good question or a really stupid question,
Okay.
so you can be the judge. So when Angelina Jolie, remember back in the day, diagnosed, she did the preventative mastectomy and hysterectomy because she had the BRCA gene. So would you consider that if you find out you have that gene as a man with prostate? Would you consider taking the prostate out? And if so, why? And if not, why?
So no, we wouldn't. So there's no genetic predisposition where I'd say, okay, prophylactically, we're going to take out a prostate to prevent you from developing prostate cancer. The reason why is the prostate itself is unfortunately situated anatomically in a place where the ramification of taking out the prostate is big, right? We have incontinence, we have erectile dysfunction, loss of fertility if you're young enough. And so there are a lot of implications to taking out the prostate. And we have an easy way to screen for prostate cancer. Even among men who have a very high genetic risk, we can tailor the screening so that we find it as quickly as possible, but preserve them as whole as possible for as long as we can.
So with like Angelina, she did that, but it was worth taking them because her risk was very high.
Correct.
Very high, and the ramifications of taking those would not have been as much for somebody who had prostate cancer.
Correct, and I don't want to get into like an apple or oranges,
Yeah, I know,
because there's a lot of psychology and distress behind having prophylactic procedures done. But it's just
it would never be necessary
correct.
for those in this. Okay,
correct.
See, I told you I have some
It's a good
weird question for you. Okay, I want to get the takeaways from this story, and I want to start with you, Matt. What do you want people to take away from you and Mike's story?
Advocate for yourself.
Perfectly said. Mike, what about you?
Well, it's a little hard to top that one.
Go for it.
I think you just ask. Make sure that they know that you'd like to have this checked. Advocate for yourself.
You can't say it enough. Guys, thank you so much. It was great to meet you, and be well and get to fishing.
Thank you, Jessica.
We're ready.
All right.
Good to see you, Doctor.
Good to see you too.
Dr. Parker, what's the big takeaway?
I mean, I'll triple down on it.
Yeah.
Advocate for yourself. I think that's been a common theme throughout these series of shows. So I really think you need to know to reach out and ask and say, should I be screened?
Are you back tomorrow?
I am.
You are? Okay, we'll see you at 24.
Yes, you will.
All right. Thanks to all of our guests. Thanks to our viewers for being with us today. We'll see you back here tomorrow. Changing the outlook for prostate cancer patients 1 pound at a time. A new study proves losing weight before surgery can help save your life. I'm Jessica Lovell on the next Open Mics with Dr. Stites. The method for dropping weight and how much you need to lose to impact survival. Wednesday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now everywhere podcasts are available.